So these, you had that lab simulator book, and the first, I think, 7 or 8 labs that you're assigned for this semester are focused on the brain also, where you're going to be given a situation about a patient doing a routine brain, IACs, pituitary, that way you kind of get a little idea of what it's like to scan. It simulates it to the best of its ability, but then again, remember, the only time you're really going to get a full hands-on learning experience is either in the lab, which we have 2 this semester, and actual clinic, okay? So this is where you're going to be mostly learning these things in clinic, but this is a good jump off for how to set up your slices, what you're looking for each sequence, things like that. So I wanted to start with a video. This is on YouTube, and it's really just a 10-minute video we'll watch of how to actually set up a scene and scan for a brain. Okay, so just kind of turn everything off, and let's watch this.
After carrying out your safety checks, bring the patient into the scanner room. Help them to lie supine on the bed with their head in the head coil. Provide the patient with an emergency buzzer and make sure they know how to use it. Provide headphones to protect the patient's ears. And put the head coil in place.
See how they're plugging those coils into the bed. It's important. Otherwise, you're not going to get any signal from those coils.
Center to the glabella. And move the patient carefully into the scanner. Make sure they're calm and comfortable before you leave the room.
So that laser light goes to ISO center. So that laser light, that's indicative of ISO.
Once you're back in the control room, select the correct patient details in the browser, or you can type them in manually if necessary. It's very important to get the details right, including the correct patient weight, so that the SAR can be calculated accurately.
Remember I said if you don't put the right SAR in, you're going to SAR out a lot more often than you
Register the patient as lying head first and supine. Select the correct protocol according to your hospital and radiologist guidelines. Begin with an initial scout or localizer sequence in 3 planes. Plan your axial sequence in all 3 planes. On the surgical...
So looking at this, what have we talked about so far? Here are our parameters. What have we talked about so far?
TRT.
Okay, TRT. This is, look at this. This is a localizer scan. So, and we have a, oh no, they've already done the localizer. So this is the T2. So what is our TRs and our TEs for T2? Remember? Short, short, long, long.
Oh, that.
Short.
T2?
Long.
Long, long. So remember, here's our TR. So I think this is a 1.5 Tesla magnet. 6,900 something. Our range was 2,000 to 7,000. And to have it longer TR, you get more T2 weighting. So closer to 7,000, it's more T2 weighting. And then our TE range, remember, was 90 to 120. It's a long TE. So we have the appropriate parameters for a T2 weighted sequence. What else on here do we recognize?
Slice thickness.
Slice thickness, where do you see that?
On the right side.
Good. Slice thickness, that's determined by what?
Slope.
Slope of our slice select gradient or our transmit bandwidth, right? If we have a narrow transmit bandwidth, we get a thin slice, which would equal like 3 millimeters. If we get a wide, we get a larger slice, which is 5 millimeters typically. SNR. What's SNR stand for up here?
Signal.
You want to keep this number around 1. You want it to hover, because 1 means basically 100% signal. Okay? So as you adjust these things, you'll take a look and you go, ooh, I can reduce the amount of time, but ooh, look what it's doing to my signal. So you always, after you mess with a parameter, look up here. And then the other thing you want to look up when you mess with your parameters is over here. What is this? TA. What do you think that stands for? It's 1 minute and 18 seconds. acquisition time. So that's what it means, acquisition time or scan time. iPad, we'll talk about that later. It's due to parallel imaging. Don't worry about that for right now. Voxel size. That's pretty self-explanatory, right? So we have 4 millimeters in the slice select direction, but then in our phase and frequency encoding directions, it's only 0.7 millimeters. So very small voxel size in those directions, but then it's pretty thick, right? So these are our voxel size dimensions, which gives us our spatial resolution. Going back to X-ray, the same thing. Pixel size gives us our spatial resolution. Voxel size gives us our spatial resolution in MRI. Number of slices. This is basically the number of slices. This big box right here is our field of view, right? That's determined by what gradient? We just talked about it. Larger field of view. Yeah, go ahead. But which gradient? Phase encoding, frequency encoding, or slice select? Frequency encoding. So our larger field of view, we usually have a shallower phase encode, or frequency encoding gradient. But these, we have 30 slices. You'll see 30 slices going like this. So it goes in line with our box here. So the slices are always with this dotted line right here. You see that? This is the middle slice of that right there. So see how you're acquiring axial slices? You see that? From head to toe? And that's what it means right here. So it says T2 blade, blade's the sequence or propeller, and then TRA is for transverse or axial slices. You see that? So we're acquiring axial slices. What do you think this is right here? Distance factor. 30%. What do you think that stands for? It's our gap between our slices. Because we actually have we have slices that are not perfectly square, and at the edges, and I'll show you a diagram, we might get what we call a cross-excitation artifact. So we always have to put gaps between our slices in a two-dimensional pulse sequence. Because you also can acquire 3D pulse sequences. All right? And this is just the positioning, so where we put our localizer. So that's the orientation, this is the positioning. Our phase direction. Look at this. What's our phase direction? Right to left. Right to left. And that's what signified by this arrow. So if you see this arrow on the Siemens scanner, that's what signifies that. So our phase is right to left, which is the shorter or longer axis of the anatomy. Shorter. Because look, this measurement is a lot shorter than this measurement. So which one's our frequency? A to P, phase right to left. Good. Phase oversampling, that's where we would have like a little voxel or box out here. If you see that on your scanner, that's just so that the anatomy out here doesn't wrap into our image. So if you have, obviously there's nothing out here, right? That's just all dead air. But if you had you were scanning an anatomy where you had other tissue out here that you didn't want in the image, you could put what we call phase oversampling so it doesn't wrap into our image. Okay? And those basically just look like extra little rectangles on the edge of the anatomy.
So if it's like a chest and you don't want the arms,
perfect example. Yeah, if you want the thorax and you don't want the arms to wrap in, perfect example. All right, what else do we have on here? Field of view. So this 230. Sometimes on a Siemens scanner, you'll see it at 230, but on a GE, they like to take it one decimal place different, so you'll only see 23. So don't get confused. On GE, it's in centimeters. On Siemens, it's millimeters, okay? So just don't get confused by that. And then we already talked about all these. What do you think concatenations mean? So concatenations mean... and we'll cover this, so don't feel like you're stressed out right now. It's where we acquire slice 1, and then we actually skip over slice 2, and we acquire slice 3. Then we skip over slice 4 and acquire slice 5. And then we go back and acquire slice 2. And that's just so that we don't get that crosstalk artifact. Because remember I said we don't get perfectly square slices, so we don't want to accidentally excite some of the protons within slice 2. So we go 1, 3, 5, 7, and then we go back and fill in 2, 4. You see what I mean? That's what it means by concatenations. What do you think averages are? We talked about this one. You should know this one. Average. Where have we seen averages in our parameters? NSA. What's NSA stand for? Or next. Remember next. So averages mean NSA. Number of signal averages. NSA. So on Siemens it's NSA, but on GE it's next. Number of excitations. That's where we're going and filling K-space, and then we go back and fill it again. So we get more signal. We boost up our signal every time we increase our next. Okay? This is, we can turn the table in. This is if we want to see live MRI. Okay? We can change our pulse, basically our protocol. This is our SAR limit down here. You see this? We're at only 11%. Once it hits 100, that's when we start to SAR out. The patient needs to cool down because we put too much energy in the patient. So you'll start this to kind of increase, and it starts to get color-coded, and it gets red up top. So once you start to get to the red, you know you're SARing out. You're heating up the patient too much. Okay? These little workmen over here, these mean that the slice parameters haven't been set up yet. You still need to work on positioning the slices. Because look how the box is not really, remember I said the box has to be at the top of the skull going all the way to the foramen magnum. They still have to maneuver some stuff. So we'll let the video kind of progress. But I just wanted to kind of point some of these things out because it's really good for you to be able to tell what's going on. Alright, so where's my...
Localizer. Axial slices should pass parallel to a line joining the inferior border of the genu and the splenium of the corpus callosum. The slices should cover the brain from vertex to below the foramen magnum. On the coronal localizer, the central slice should pass along a line from the superior sagittal sinus, through the third ventricle, and down the center of the brainstem.
So you're just aligning everything.
Center the axial localizer in the field of view. And apply. Now plan the next axial sequence. You can copy the planning and centering from your first T2 axial.
So they're just copying parameters because they basically want all the same slices and sat regions. So they're good there, and they'll just hit OK. And what that will do is just plan the rest of them.
Make sure the coverage and centering are correct. And apply. Repeat this process for the T1 and any subsequent axial sequences.
And sometimes you'll see a little copy thing. So number 3 will copy off of T2. So once you set up step 2, you'll be good for all the next transverse slices. The only thing you'll have to set up after that is your coronal and your sagittal. You see that?
Now plan your coronal sequence using all 3 localizer planes. On the sagittal localizer, the coronal slices should run perpendicular to the line from the genu to the splenium of the corpus callosum. Ensure that the slices cover the entire brain from frontal sinus to the posterior occipital lobe. Center the image in the coronal field of view. Plan the sequence on the axial view. The slices should run perpendicular to the midline of the brain, with the center point lying over the midline.
But you see how as you adjust one, the other 2 kind of get shifted too. So you always have 3 planes up when you're positioning, okay? Because you have to position it at all 3 orthogonal planes.
Plan the sagittal sequence.
You'll see, since this is a sagittal image, right? This is a sagittal brain. This is a sagittal sequence. You'll see just field of view box anytime you're doing that plane. But then you see the slices in the other planes. You see that? So that way you know you're going to get a sagittal image here. But if you accidentally, you were selecting a sagittal, and then all you had was the field of view on this coronal image, something's wrong. You see what I mean?
Just the image in the sagittal field of view. On the coronal localizer, the central slice should run parallel to the midline of the brain. Make sure you cover the full width of the brain from side to side.
So we got to add slices.
Center to the midline on the axial view, and again, cover from side to side.
So here is that phase over sample right here, this extra little rectangle. So see how it's at 50% now? And then when I originally showed you it was at 0, that's what that means, this extra little area right here. So we don't get any wrap. Because sometimes the nose of the patient might wrap into the back of the head. So we put phase over sampling so we don't excite the hydrogen protons of the nose and it wraps into the back of our image.
The diffusion axial slices are planned parallel to a line from the glabella to the foramen magnum. This reduces artifact of the border between the paranasal sinuses, which contain air, and the denser bones of the skull base. Be sure to cover the whole brain from vertex to foramen magnum. Center to the midline in coronal and axial views.
Some people don't change the slice orientation for your diffusion, but this is a good
If
idea.
the radiologist has requested a gathering
Diffusion, sometimes this area signal void in the sinuses creates an artifact on the diffusion scan. So if you do see some people that just change their slice orientation just for the diffusion, that's what they're doing that for.
Premium injection, it's essential to check the patient's kidney function in line with national and hospital guidelines. Only proceed if it's safe to do so. When planning the post-contrast sequences, axial planning can be copied from the pre-contrast T1 sequence. And the coronal post-contrast sequence can be copied from the pre-contrast T1 coronal.
So they're just right-clicking on that and going up.
Once the pre-contrast sequences are complete, make sure the correct contrast name and volume are entered into the scan details, following radiologist or hospital protocols.
What kind of contrast do
Remind
you
the
use?
patient to lie still.
Prohance. And the other one's Dotarum. So usually if they've had some kind of contrast reaction, Dotarum's the choice. But normally we're going to go with Prohance.
As they may need to be moved out of the scanner to administer the contrast. Inject the contrast following the hospital manufacturer's guidelines. Check that the contrast is not tissued or extravagant.
These are the coils within the table. Remember those phased array coils that I talked about last unit in instrumentation, where you have coils as you go down the patient's spine? These are basically showing where those coils sit, so you can excite the different coils and turn them on or off.
Conversated, and that the patient is feeling well before you leave the room. Now continue with the post-contrast sequences. You should review your images as the scan proceeds. In T2 images, fluids and fat will appear bright. Most pathologies will also appear bright on T2. FLIR is a fluid attenuated inversion recovery sequence. Fat will appear bright, but fluid will appear dark, and most pathologies will appear bright. FLIR sequences are useful for showing pathologies close to the ventricles and sulci, where the CSF shows bright on normal T2
Find
sequence.
out those white matter lesions right there.
On the T1 sequence, fluids appear dark, fat is bright, and most pathologies will appear dark. This is a coronal T1 sequence.
So she's able to flip
And this sagittal is a
through those
T2.
slices on her keyboard, but if you needed to flip through them, you can hit these little triangles. These flip through the slices too also.
Sequence. This B0 diffusion scan sequence looks quite similar to a T2 because the diffusion value is 0. This is a B500 diffusion sequence. And this is a B1000 sequence with a high diffusion factor.
So we typically
Here, areas of restricted diffusion, such as stroke, will appear bright.
And here's our ADC.
This is an ADC, or apparent diffusion coefficient map, where areas of restricted diffusion now appear dark. This is a T1 post-contrast axial sequence. In this case, you can see multiple enhancing lesions. In comparison to the T1 non-contrast axial scan.
And she's going to the same slice. That's what you want to do. When you look at it, pre versus post, you want to find the same slice. So she goes up here, and look, she's at 16 of 20. This is 16 of 20. So see how that lesion's bright on the post-contrast, and then you can't even see that lesion on the pre-contrast. That way the radiologist is able to determine, oh, those are MS lesions. Okay? And you can see the choroid plexus is within the ventricles are lit up. You can see the vessels kind of surrounding the brain here are lit up with contrast. You don't see that over here. So that's the way you know that I injected the contrast correctly. Okay?
On the T1 coronal sequence, the lesions are again visualized as bright areas.
All right. All right, so I hope that's kind of helpful in how to kind of set up for your initial brain scan that you're going to see in clinic. And remember, these are the things that you should be attacking first: brain scans and spines. Okay? Those are kind of your easier, more like chest x-rays of MRI. All right, so everybody here's had cross-sectional anatomy, right? Let's have a little quick refresher. All right, so if you have your slides with you, let's try and point these out and name these structures. First of all, what type of weighting do you think this image is? Okay, and how were you able to determine that? Good. So looking at our CSF, which we only really see right here in the lateral ventricle and surrounding the spinal cord, is dark. And our fat surrounding the skull is really bright. So T1 weighted. What type of scan plane do we have here? Sagittal. And we're really sitting mid-sagittal plane. This is right in the middle here. If you're able to see the corpus callosum, most of the time you're sitting right in the middle of the patient's brain. All right. Does anybody know what A is?
Superior sagittal sign.
Good. So we'll roll through these because I don't want to sit here and wait for a refresher. So A, superior sagittal sinus. B, parietal lobe. C, frontal lobe. D, genu of the corpus callosum. E, thalamus. F, optic chiasm. That's where those optic nerves converge. G, pituitary gland. Very small. What does the pituitary gland sit in? Nice. There we go. There's a little refresher. All right. H, pons. I, subcutaneous fat. It's bright. T1. J, anterior horn of lateral ventricle. Anterior horn. So remember, we have anterior and posterior horns, but that's the anterior horn. K, splenium, the posterior part of the corpus callosum. L, cerebral aqueduct. So where is that between what two structures?
Corpora quadrant.
Rachel was close, but what ventricle is this right here?
Fourth.
So it's between the third and fourth ventricle. So good. She knew it was between a couple of ventricles. Just she said lateral and third. So that's the cerebral aqueduct. You can see that, just kind of a very narrow structure. M, fourth ventricle. So right in front of this cerebellum. N, cerebral tonsils. So the very inferior part of the cerebellum. And that's usually if you have what we call Chiari malformation. They can dip down below the foramen magnum. And then O is our spinal cord. Okay? What weighting do we have here?
PD.
Nice, PD. So very gray image, fluid's gray. We can really see the difference between our white and gray matter. What is the darker part? Is that white or gray matter?
White.
White, good, because it's closer to the corpus callosum, which is a white matter structure. And then the brighter area of the brain is our gray matter. A, cerebral cortex. B, genu of the corpus callosum. C, is the caudate nucleus. These are the ones I always get confused, like right here, here, and here. Caudate nucleus, the internal capsule, so it's between the caudate nucleus and the lentiform nucleus. So we have the two nucleuses, and then we have the internal capsule in between it. F, thalamus. Thalamus, very big spot for any kind of acute stroke, lies up right against these lateral ventricles. Oh yeah, E, lentiform nucleus. G, right, because remember this is our patient's right side, so we're looking at their feet. Right posterior horn of the lateral ventricle, and then H is the splenium of the corpus callosum again. So that's that white, it's pointing at that white matter structure. These are on the slides. Need a refresher. All right. What plane do we have here? Good. And what type of weighting? Be more specific. T2 what? T2W, I like that. T2 weighting. T2 what? What's dark that normally is bright on it? Good. See that subcutaneous fat is completely nullified. So this is a T2 fat satted image. Fat sat. So put an FS behind that T2W. All right, A. Once again, this is our superior sagittal sinus. B. Longitudinal fissures where it's dividing the two hemispheres of the brain. So if we're doing a sagittal slice, we want to align it right with that longitudinal fissure. C, this is our body of the corpus callosum. So we're more in the mid portion of the brain, not at this genu or the splenium. We're right in the middle of the corpus callosum. So we're right kind of mid coronal plane. D, that is our right anterior horn of the lateral ventricle. E, sylvian or lateral fissure, it's kind of the most pronounced fissure within the brain, divides what lobes of the brain? What's this lobe of the brain right here?
Temporal.
Temporal lobe. Then what do we have up here?
Parietal.
Very nice. All right, what is F? Lies right up against that corpus callosum. We've already talked about that. Area where a lot of stroke. Thalamus, good. G, This is our hippocampus. So this is really important when we're imaging patients that have epilepsy. We want to see that hippocampus in profile. So we actually angle our slices with the hippocampus 90 degrees from it to get coronals so we can see the temporal lobes with the hippocampus in view. The hippocampus, part of the temporal lobe. H, that's a tentorium, almost like a tent over our cerebellum, right? So you guys see how it comes to a point. It looks like a tent, tentorium. I, fourth ventricle. J, cerebellum. That's where we get most of our cognitive ability. So once again, these are in the notes of part of the slide if you need. All right, so why do we scan the brain in MRI? Well, here are one of the many reasons, right? So the main reasons: tumors, TIA, CVA, infections, meningitis, inflammation of the meninges that surround the brain, any type of autoimmune disease, HIV, AIDS, TB. What's TB stand for? Nice. Cognitive decline. So think our dementia patients, Alzheimer's, those things that you might be considering for your final paper, right? Myelinating diseases, MS, white matter disease. You know, young women are more susceptible to MS, where you start to lose function of your extremities because you're losing that myelin sheath around those nerves. Lesions, congenital abnormalities. Some people aren't even born with parts of the brain. And they're still functioning, which is amazing. I mean, it is amazing what the human body can do, but some people don't even have a cerebellum. Some children are born with that, and they're still relatively functioning. Vascular pathologies. So aneurysms, stenosis, where our arteries narrow through arteriosclerosis. Any type of dissection, where you have almost a cut right through the middle of an artery or a vein. And then you have your kind of more less serious things, headaches. And you'll be amazed by how many people who come in for an MRI scan just complaining of headaches. But maybe that headache could lead to something else, which would be bad, but maybe they'll have a reason why they're having those headaches. But a lot of people you'll see have come in for just headaches. Trauma, they get in an accident, they don't really know, they can't rule something out on a CT or X-ray. They might do an MRI. Ataxia, what's that mean? Just relative imbalance. So ataxia, you'll just see that kind of, those motor skills are really kind of starting to fade. And then post-operative follow-up. So sometimes they're planning out a surgery on the brain. They have a tumor in the brain. They're trying to plan out surgery. They might do pre- and post-operative MRI scans. So then I put anything in bold typically is going to require contrast. So if you see any of these in bold and they don't have a script that says MRI brain with and without contrast, you might have to call their physician and have them fax over another order. Because typically these are the things, infection, tumors, MS, that need contrast to really enhance those lesions. So if they don't have that on the order, make sure you consult with your radiologist first and be like, hey, it looks like I didn't order this for this patient. Do you think we should have this scan with contrast? And they'll be like, of course. And then you have to call over to their ordering physician's office and have them fax over a new order. So you have to be kind of clued in on, what certain pathologies require a certain type of imaging. All right, patient prep. So remember, we can't bring anything ferromagnetic into the room. So just kind of dealing with the head, we really need to make sure we remove that hearing aid. Remember, they're not necessarily going to be harmful to the patient, but it's going to create a massive signal void. Same with dentures. A lot of people have those metal dentures that they can remove and just have like a little cup for them to put their dentures in so they don't get misplaced. Have the patient change into a gown. Why do we not keep them in yoga pants?
They got
Material.
silver.
Yeah, they have potentially some metal within that moisture wicking fabric. Give them that call bell, because we need to monitor the patient visually and verbally, right? We're going to deal with a head coil, so we need to remove any type of hairpins, jewelry, earrings, and then just instruct the patient to remain still. How long do you think this is going to take? Huh?
30 minutes.
30 minutes. Give them a time frame. But don't ever undershoot your time frame. Don't say 10 minutes, and then they're in there for 30 minutes, and then they're going to be mad at you. They're going to be like, why did that take so long? Be like, oh, I gave you the wrong time frame. So brain without contrast, you could say 30 minutes. With contrast, like 35, 40 minutes sometimes, because you have to add a couple extra sequences.
Question.
Yeah.
The hearing aids, they can't wear them inside that MRC, right?
No.
Because I've seen them, like, some people have, like, these smaller ones, and I think they take them in and they remove them, something like that. I saw somebody.
Well,
do that.
remember, contraindicated completely, cochlear implant. So if that is hooked to something that's attached to their skull, contraindicated completely. Because that can malfunction and that they could never possibly hear again, unless they go get the cochlear implant fixed, which could cost a lot of money. But hearing aids, I mean, there really isn't, but it could burn, right? There's a lot of electronics in there, but it doesn't. So people are a little more nonchalant about that.
Right.
But patients pay a lot of money for hearing aids. They're not typically covered by insurance sometimes. So don't screw up their device because you were too lazy to ask them to remove.
Yeah, I've seen them remove it. They just kind of, like, put it, like, on the counter or whatever. When
And
they're
that's
done.
fine. And, like, they're in the room, but remember, they're outside that 5 gauss fringe field. So they're okay. And it's kind of just to reassure the patient, like, I'm taking them off, but I'm just putting them right here.
Yeah.
You know, so we don't forget them. But they're outside that 5 gauss line. That's the really big one to not go inside. But don't take the hearing off before you go through the screening form, because remember, they need to hear your questions. All right, positioning-wise, we saw in the video, head first supine. There's really no other way to do a brain. So if they can't lay on their back for 30 minutes, it's going to be tough for them. I've had patients where they're so kyphotic, we tried to boost up their legs, but there was just no way we could fit their head into that head coil. And you can readjust the head coil some ways. You can kind of prop a sponge under it sometimes, kind of adjust for certain positioning needs. But if they can't lay flat for 30 minutes, this is going to be a hard test for them. Any type of hearing loss with these acoustic gradients, these acoustic noise ramps up, our decibels go up because of the gradient switching on and off very rapidly. We need to have earplugs or headphones. Headphones, typically if you're giving contrast or if they're claustrophobic, talk to them, get them through the scan. Cushion under the legs that you see here, that helps their lower back. And put cushions and sponges around their head. Because even if they seem like Jasmine, I have a feeling you can get through the scan in 30 minutes, but you're not going to realize how much you move your head around. So if they have those sponges right up against their head, they're less likely. And sometimes they have these things that push their head, you know, so you can tighten it up so it reminds them not to move their head. So our central laser light, which puts the patient at isocenter, we want to position that laser beam at the nasion for some scans and the glabella for other scans. So that scan said the glabella, but the nasion sometimes aligns with that pituitary gland. So whatever part of the brain you're scanning, posterior faucet's a little more inferior, center that laser light there because that's isocenter. That will give you the best fat saturation. Remember to have the patient close their eyes or put their hand over the laser light so you don't harm their retinas. Clip the coil on and plug it in. Sometimes you think it might be plugged into the table. Just make sure it's nice and secure into that coil. All right, so I always include the Emory protocols. So just be mindful if you happen to go work somewhere else after graduation. Hopefully you stay within the Emory system, but Emory has great protocols. So even if you work somewhere else, they're going to be very similar. But I just kind of give you the general routine brain and routine brain on a 3 Tesla and then with contrast too. Okay, so these are the sequences that we're going to be running. See here how it says, if you guys have these protocol books in every department. So if you see on the patient's name, you'll see all these neuro exams get protocoled by the radiologist. All the fellows or residents are going to be protocoling these scans. And if it says B1A, you go into your book, flip to the page, and select that sequence. And all your scanners will be labeled B1A, B2A. So it kind of makes it dummy proof, right? But make sure when you bring over that pulse sequence that all the scans come over. Because sometimes they might, for some reason, leave out the sagittal T1. So make sure you have all these scans before you get the patient off the table. Okay? So you can see here mostly axials, and then you get a sagittal. This one starts with a 3D sagittal, and then you get all axials. Here with contrast. So if you see that plus C, that just means with contrast. Here's a routine brain with contrast. Here's a routine brain with perfusion study. So we're going to be injecting contrast very rapidly, trying to observe the blood perfusion within the brain. Here are some of the indications for these type of scans. The routine brain, just routine. Here's one with needs on the 3 Tesla. These are some of the reasons. Here are some other reasons. Okay? So they should be matching up. All right? Our first scan that we get is our 3-plane localizer. This is a very fast sequence, usually just a quick T1 weighted sequence. Very low resolution, very low signal. Remember, we're going to send this to the radiologist so that they can see how you set up your slices, but they're not really going to be reading any anatomy or pathology from these scans. It's just kind of quickly so that we can see how the head's positioned so we can set up our other slices. Usually these are T1, gradient echo, low resolution scans. And then once you get all 3 planes, you throw them up into your header part of your Siemens console so that you can set up all your scans. Typically, a lot of people like to do the T1 sagittal first, because if you get a good T1 sagittal, it makes it easier to set up your axials. Because we get a better, because sometimes on your localizer scan, you might not be able to see the corpus callosum very well. So what they do is they run the sagittal first, the T1. This is what the image looks like over here on the right. Dark fluid, bright fat, sagittal slice. We're basically getting the entire, we have a very large field of view. We're getting the entire brain with some of the other components of the head. And then this is how we're setting up the slices. Once again, I said it's a sagittal slice, so then you should see the field of view box, and then you angle the box accordingly with the other 2 planes. So some people you'll hear say cover bone to bone, right? So you cover from temporal bone to temporal bone. Because you do not want to miss any part of that brain. Cover all the anatomy. What's this little area right here, this little extra? Phase over. What's this arrow signify? Phase encoding direction. Yeah. Phase oversampling and phase encoding direction. Sometimes you have to increase your phase oversampling to prevent. See how the nose is starting to creep in? It will wrap into the back of the brain. So if you see that nose wrap into the back of the brain, know you either need to increase my field of view or I need to increase my phase oversampling. Okay? It's your first artifact you'll probably run across.
In that area, what you said is called phase over?
Phase oversampling.
What was the arrow again?
Phase encoding direction. Because remember, that's the shorter axis of the anatomy. So in the sagittal, it's going A to P. And you can see it also, here's the arrow also. So always be mindful of those arrows. All right. Oh, you okay? Alright, so now our axials. Remember in the video, they were angling with the corpus callosum, and they're angling with the genu and this polinium. They're basically splitting the difference. See that? And they're covering from the top of the skull all the way down to the foramen magnum. So some people angle with the corpus callosum, some people angle with the hard palate, which is basically right here. It really should give you about the same angle. But some people are so insistent on, like if you set it up with the corpus callosum, the head smacks your hand and goes, no, you angle with the hard palate, that's just personal preference, okay?
What do you angle?
I did the corpus callosum. And you'll find, I think, 70% people do corpus callosum, 30% do hard palate. But don't correct the tech and say, no, it's the corpus callosum. There are other ways to do this. But it should give you about the same angle. Because remember, we do that because imagine if a patient's head was like that. We need to still angle our slices to get a good axial slices of the brain. So if their head is like this, or like randomly in the coil, in all different ways, we can actually adjust our slices appropriately. Alright, so we talked about the parameters. I pointed them out on that Siemens console. But generally, for axial scans, our slice thickness is going to be 5 millimeters. Because we're not really concerned with getting 3 millimeters like our MSK imaging. 5 millimeters. So our voxel size and thickness over here is going to be 5. Okay? And then, if you get, this is your thickness, but then our matrix is determined by our phase and frequency. So this is saying 320 by 320. There's 320 lines in the phase direction, and there's 320 lines in the frequency direction. That's what that's saying. So that gives us our grid, or our matrix. So we have a matrix of 320 by 320, not any different from X-ray, right? Our field of view is this entire thing right here. That's our field of view. Our slice thickness is this. That's our slice thickness. Slice thickness is determined by transmit bandwidth. Field of view is determined by frequency encoding direction. And the number of pixels is determined by our phase encoding direction. Okay? And the reason we have this 10% slice gap, right here, 10% slice gap, is because of this right here. This is what we call crosstalk or cross-excitation, where this is what we would want, ideally, where our slices are perfectly squared off. That's what we would think that happens with our system. But what really happens is actually we get this little curve right here, where some of the slice from, say this is slice 1, this is slice 2, this is slice 3, some of the spins in slice 2 get excited with slice 1, and that's what we call cross-excitation or crosstalk. So we'll get a misrepresentation of the data. So we don't want that to happen, so we put this little gap right here that's only 10% in between our slices. So we might miss some information, right, because we're not covering the entire brain. But typically with a slice gap of only 10%, we're not going to miss much. Okay? So if there happened to be a tiny, tiny, tiny little tumor within that gap, we're just out of luck. Okay? But if that tiny, tiny tumor's there, it's not really causing that big of an issue, unless that's something that grows into something bigger over the course of time. So remember, I mean, MRI is great, but we still have some potential of missing stuff. It's not perfect. All right, and then so here's what our T2 axials are going to look like. Here's the top slice. Remember, we should get all the way to the top of the brain, but this is the top of the head, so this is more superior. This is more inferior. You see that? top slice, bottom slice. T2 images, our fluid's going to be bright, just because it relaxes. Fluid relaxes or decays a lot slower than fat. So our fluid's going to be bright. You can see within the folds of the brain, you can see the fluid. You can see it within the globes of the eyes, and then you can see it within the ventricles and around the spinal cord. You can also see fluid in the sinus cavities. What sinus cavity is this? Maxillary. So this person has some serious sinus issues, right? And don't be frightened by that, because pretty much everybody on the planet has sinuses that look like this. You'll be like, oh my god, they have a tumor in their sinus. No. Everybody has fluid, some kind of fluid within their sinuses. So T2s, are they great for seeing pathology or anatomy? Pathology, because a lot of tumors and different things are water-based. There's a lot of water content within a lot of pathology. So that's going to appear bright on our T2 images. And that gives us very high contrast noise. So T2, high for signal for water, high contrast to noise ratio, and they're great at detecting pathology. Here's our FLIR images. FLIR stands for Fluid Attenuating Inversion Recovery. Okay. So we are nullifying signal coming from fluid, and what's the only fluid in our brain? CSF. So those ventricles better be completely dark on our FLIR images. Otherwise, we, for some reason, didn't invert fluid. We might have inverted something else, which would be bad. So FLIR imaging has taken the place of what? What did I say we used to scan in the brain, and then no longer, because we have FLIR imaging? Proton density. We used to have proton, because remember, proton density showed a really good contrast between white and gray matter. FLIR does that, but it also nullifies fluid from the ventricles so that we can see these lesions. So right here we have the MS plaque, right here, running up against this lateral ventricle. And it would have been harder to see that MS plaque if these ventricles were white with fluid. So what they do is they nullify the fluid so that we can see these a lot easier. Because they're not always going to be that big, right? They might be smaller, so it's easier to detect these. Yeah.
As far as like the TR and TE ranges for FLIR, is it the same as the?
You can have T2 flares and you can have T1 flares. So typically if you have a lesion that appears bright, what do you think? Pathology bright, T2. So then you're going to have longer TR and longer Ts. But you can't have both. You can have a T2 and a T1. Typically, flares are going to be T2 based. So we'll talk more about this in our coverage on pulse sequences, but this is what we call an inversion recovery pulse sequence. You can have two different types, a stir, which is a short tau, and a FLIR, which is usually a longer TI. But this is what's happening. So this is no different from what I showed you guys in physics class. Our first line is our RF pulse. Our second line is our slice select. Third line, phase encoding gradient. Fourth line, frequency encoding gradient, or also called readout gradient. And then our signal is the last line. What's happening in an inversion recovery is we actually, instead of starting with a 90-degree excitation pulse, we apply a 180 excitation pulse to flip all those tissues, not 90, but 180. And what happens with 180? Full saturation, good. So what we actually do is we flip them all the way to full saturation, we turn it off, and we allow those tissues to fully start to recover. And once they hit that transverse plane, because remember they're at 180, the transverse plane's here, all these tissues are recovering. And remember, they still recover with that same T1 recovery curve. Once fluid passes the transverse line, that's when the pulse sequence starts. All the other tissues may have passed it, but once fluid passes that transverse line, we start the pulse sequence because you're going to be you're going to saturate, now it's going to be on the transverse plane. We hit it with another 90-degree excitation pulse, goes down to full saturation again. So that's how it saturates out fluid. You can do that with fat, or you can do it with water. And usually you set a TI time, an inversion time, specific to that tissue. So with fluid, our TI times are typically longer because fluid takes longer to recover. We've already talked about that. So our TI time with a FLIR is 1700 to 2200. So that is one thing you should remember when you're setting up a FLIR sequence. 1700 to 2200 TI time. Your stir TI time is going to be less. We'll talk about that later. But the most important thing to remember is basically this whole beginning of the sequence is what causes our inversion recovery. That is completely different from what we've learned so far. In the past, we've learned from here on. But what happens with inversion? We start with a 180 compared to a 90, and we flip all those tissues into full saturation. We allow all those tissues to recover. They all recover at different rates. And we select a TI time specific to fluid so that once it hits the transverse axis, we flip it again 90 degrees and it goes back to full saturation. No signal from that fluid. That's what's happening with an inversion recovery pulse sequence. So this is just showing how you calculate that null point, that inversion time, that tau, TI time. Is basically the null point is the time it takes the tissue to recover from full inversion to the transverse plane. Because remember, 180, it flips at full saturation. All those tissues start to relax. And you can see fat always relaxes faster than water. So we let it relax so that there's no longitudinal magnetization corresponding to the tissue. So fluid, once it hits the transverse plane, we apply another RF pulse. The 90 starts the pulse sequence, and then boom, it gets flipped back down to full saturation. There's going to be no signal from fluid. So to calculate the null point, it's the TI required to null the signal from the tissue. So it's basically 0.69 times T1 of that tissue. So this is an equation you need to know for the registry. The test registry, please remember this equation. TI equals 0.69 times the T1 relaxation time of whatever tissue you're trying to know. TI equals 0.69 times T1 relaxation time of fluid or fat, whatever tissue you're trying to know. So I also put on here proton density just in case you're at a facility that still does proton density imaging. I doubt you'll see it for any brains, but maybe sometimes they still throw them in there. But remember, the fluid is gray, and we see a great difference between white and gray matter very well on proton density. All right, we'll stop there before we get into diffusion. This is a good point to stop. Any questions? Which one do you find easier? Studying more about the brain or about how the physics and everything works? Procedures is easier.
Yeah, but I also think that they're kind of dependent on each other.
They are, and that's where I wanted to show you guys. It's like, it's not only just setting up the slices, it's knowing what these sequences are looking for.
Yeah, I'm just saying like the kind of
Exactly, yeah.